We are going to jump right in today. I am going to moderate this discussion, and I'm Linda Howard, and I'm the Chief Compliance and Impact Officer for Muslim Life Planning Institute. And today is our 5th episode of Profound Conversations. Jumping right in, we are going to look at some of the issues that were revealed in the Global Health and Security Index. And when I looked at that report, it reviewed about 195 countries. And one of the profound statements that came out of that report was, national health security is fundamentally weak around the world. No country is fully prepared for epidemics or pandemics, and every country has important gaps to address. Now, this is the report for 2019, so a lot of this work was done pre-COVID-19. Now, while the US overall score ranked at number 1 out of 195 countries, that number does not break down the US by communities. And what we know and what has come out through some of our other profound conversations is that the coronavirus pandemic is amplifying pre-existing social inequities tied to race, class, and access to healthcare systems. So we're going to break down the parts of the US. We'll look at it at a global level, but we also want to break down the parts. And today we will add to the discussion Detroit. The last couple of sessions, we had speakers that talked about some of the issues in the Baltimore area, but today we're going to bring in another part of the country into the discussion. So I want to start with Dr. Josh Sharfstein, who is with us from Johns Hopkins, and I will allow Dr. Sharfstein to just give us a little bit of information about what you do and why you do it.
Thank you so much, and thank you for having me on. I am the Vice Dean for Public Health Practice and Community Engagement at the School of Public Health at Johns Hopkins. I'm also a pediatrician, and before I came to the school, I was the Health Commissioner for Baltimore and the Health Secretary for the state of Maryland. At the school, I teach classes, including class on the opioid epidemic, class on public health policy, and a class called Crisis and Response in Public Health. And so I'm very interested in public health crises, not just as emergencies, but as opportunities to understand where there are needs for major improvements in our public health infrastructure. And, you know, I've been tracking the COVID pandemic from the beginning and, you know, both trying to understand with my students, you know, how the response is going and the weaknesses in the response. But I think the point you made is very important, that epidemics and crises expose and amplify existing inequalities and inequities, but they're also provide a path for people's understanding of those, and hopefully a path for a better approach that can close some of those gaps in the future.
Dr. Sharfstein, are you familiar with some of the findings of the Global Health and Security Index?
Yes, at a broad level I am.
Okay.
I was not involved in putting that report together, though.
Okay. I know Johns Hopkins was involved, but you were not personally involved.
Not personally.
With the report. Okay. So if you think about some of the statement that I made in the beginning, is that, you know, no country is really prepared. All of the countries, the 195 countries, left something to be desired, and there were gaps. And this was pre-COVID-19. Do you have some thoughts around how we have dealt with this pandemic at a global level?
Well, the reason the United States was first in that survey is because of the fact that we have a very technologically advanced healthcare system. That's not to say that it is a fair or equitable healthcare system, but very technologically advanced. We have a lot of ventilators, for example. Relative to other countries, as you may know, there's some countries that have 0 ventilators. There's some countries where the ratio of intensive care unit beds to the population is like 1 per million, whereas ours might be, I think, in the order of 1 per several thousand. And so what I'm worried about, so there are different risks in every setting, and there's just an enormous global risk from this illness, which we're seeing in different countries. You know, India is having very fast growth, and there are a lot of people who live in India. Iran had a very serious problem. There is a huge risk to countries with a lot of people, particularly a lot of people living close together. And not very technically advanced in the sense of many hospital beds. And that keeps a lot of people, including myself, up at night worrying about what can happen there. But one interesting aspect is that many of those countries have reacted a little quicker with the public health measures than we have in the United States. So it has not been immediately such a big challenge in a lot of countries because they very quickly enacted social distancing, and some of those countries actually have very robust public health systems, for example, from going after Ebola and other infectious diseases. So in some respects, some other countries are better off than us, but on the other hand, as cases start to rise and you really need more advanced medical treatment, it's very worrisome.
So how do you think the US has done compared to other countries in response to this pandemic?
I think there are strengths and weaknesses of the U.S. response. I think the strengths are that we were able to turn our lives around very quickly. And in doing so, we averted the collapse of our healthcare system. I mean, there's no doubt in my mind that if we just kept doing what we were doing, we would have seen like what happened in Italy happen in the United States, where people were expressly rationing ventilators and many people died with other diseases because they couldn't get any care, and that kind of catastrophe we were able to avoid. And that was because people really did do what they needed to do to physically distance from each other. So, I mean, I would put that in the relatively, positive category. But at the same time, I think we have not reacted as quickly to set up the structures that we need to be preventing illness, and particularly in the most at-risk communities. We have not had protective equipment for healthcare workers and other essential employees, for grocery store workers, for bus drivers that we need. We've been way behind in that. We have not been able to set up testing very effectively. We've had political disputes and all kinds of, finger pointing instead of, national leadership to work together. And I think the result of that has been a choppier response than we really needed to have. So I think the US response could improve a lot. I really hope that we're able to find effective treatments and a vaccine as quick as possible. But we can't bet on that. We have to assume that we won't, and that we're going to need to find a path to working together, to address these challenges that are now clear and right in front of us.
Now, when I look at some of the things that have been happening in certain communities throughout the US with the pandemic impacting particularly Black and Brown communities in a way that it has not impacted other communities. And I know we have not seen the wave in some countries around the world, but when you look at the index in terms of the readiness for pandemics, we have a lot of countries who are ranked very low and who are not prepared at all for if there's a pandemic. And I'm wondering what is it that we could do differently, learning from some of the mistakes, and what might be some things that some of the countries can do that are ranked pretty low with respect to their readiness?
Well, in terms of what we can do for our mistakes, I think we have to set aside all the politics, set aside all the ideology, and look, what is this virus actually doing to us? Where is the virus causing problems? And just like you said, there are communities that are hit much harder than others. what can we do to help them? What are the underlying causes of that increased risk? How can we address those? And I see Dr. Cooper is here, so I'm sure we'll talk about that. We've written about this some. You know, I think we have to stare these things right in the face, and sometimes in the United States we haven't been willing to do that. The housing crisis, for example, that keeps people unstably housed or living close together. The food crisis, where so many people are food insecure. The transportation challenges, which keep people, you know, stuffed in buses for long periods of time instead of more easily able to move around. These things are risk factors now. And the fact that low-wage workers are often treated so poorly, these are things that put us all at risk from the virus. And so I think it's important to be talking about these things. There are other issues too, how prisoners are treated. You know, that's a huge risk for infection. How nursing home residents are treated, and our very, you know, unstable system, you know, with a lot of problems that we've had in taking care of older adults. Now it becomes this huge weak spot. And how the homeless, people experiencing homelessness are treated. These are things that don't dominate the headlines, you know, when there's not a pandemic, but it is really important to pay attention to them. You know, Singapore is an interesting case, because Singapore has had one of the best public health responses to the virus. And in the first wave, they were able to control it entirely through a fantastic public health system. But they've had a huge surge in cases, thousands of cases, and they've had to shut down their whole country to deal with it. And essentially all of those cases are in immigrant workers, who turns out live in dormitories, 10 to 20 people per room. And so, you know, I'm imagining that those workers were not, you know, front page news before this all started. You know, that like some of the different areas of the United States, that it wasn't a big focus. People probably just took them for granted. And maybe I'm surmising too much, but this is a virus that seeks out, you know, any opportunities to transmit. It doesn't know who's socially favored and who's not socially favored. We've got to be able to take off all of our preconceptions and really focus on where the risk is if we're going to be able to be successful. You know, to your other question about countries that are really in harm's way because they don't have the resources, I think it's really important for the global community to stand by them and help, and try to get them low-cost ventilators, try to get them protective equipment for their healthcare workers. Otherwise, we could have a total devastation of their healthcare systems.
Yeah, and one thing that we do know, what I think if people did not know before, the COVID-19 certainly educated us that viruses know no borders. And so when we talk about what do we need to do for the US, when we leave out the global community out of the discussion, it doesn't recognize that we are one world, and what is happening in one part of the world will ultimately impact other parts of the world. And I see we have Lisa Cooper that has joined us, and Lisa, Dr. Sharfstein has a limited amount of time, but I do want to prepare you because I will ask, I know that you have some experience in working in sub-Saharan Africa. Mm-hmm. And so I will, you know, ask you to kind of weigh in on what may be happening in that part of the world. And Patti is back with us, and Patti is in Detroit. Mm-hmm. And we know that Detroit is also a real hot spot. So we're going to have this discussion at a global level, and we want to have it at looking at some of the communities. So I will just ask the two of you to really get ready to be able to join in on the conversation. And because Dr. Sharfstein has about 10 more minutes, maybe, with us?
Yep.
Okay. And his time is short with us because he's out there doing the work. And I know you've had a number of meetings, and I think you've been doing some work with in the state of Maryland as well. Can you talk a little bit about maybe what you're doing? And I know you have another meeting that you're running to after this. Do you mind?
Sure. I can just say, you know, the other meeting has to do with the report that we've worked on for the National Governors Association, which makes some of the points that I just made, that says states really do have to, use the science, look at where the virus is, and rethink some of the, you know, really invest in approaches that are going to be successful. So that we have a release of that report coming up. In Maryland and in Baltimore, Johns Hopkins is very, very involved, and Dr. Cooper can speak to this also. We've set up in Baltimore a public-private partnership with the city. It involves Johns Hopkins, University of Maryland, and others working closely with the city in a bunch of different areas. It involves clearly coordination around medical issues like Johns Hopkins Hospital, the establishment of an alternate care site at the convention center, but it also includes things like a call center for people who may not have access to healthcare through their doctor. Maybe they don't have a doctor, but they can call the call center and they can get a telemedicine doctor right away and get referred for a test and eventually treatment. So we're creating paths to treatment for people who may not have them otherwise. There's also a big effort to support the social stability of people in Baltimore, including through efforts to expand access to food. And the university is one of the city's partners in that, as well as emotional and mental health support. There's an amazing effort that was actually a grassroots effort in Baltimore called the Baltimore Neighbors Network, where hundreds of volunteers are calling thousands and thousands of people at home to check on them. And there are also volunteer therapists who are on call in case people, you know, really sound like they're in trouble, to bring in a professional to help. And there are many, many students at Johns Hopkins and elsewhere who are participating in that. So it's a broad range of things. There's a lot of work going on with the city health department, the state health department. It's a kind of an all hands on deck moment for our region, as it is for the science of what can be done to address infections.
So if you mentioned a couple of ways that people can volunteer. So if someone on this call wanted to do that, how would they go about it?
That's a good question. I think if it's somebody who is living in Baltimore, the best thing to do would be to probably call 311 and ask, you know, for volunteer opportunities. If they have a particular area that they're living in the city, to probably talk to their neighborhood association, because they may have different activities going on. There's also, it's possible to sign up for the mayor's messages, which talk about different events that are happening. So I know that there are many, many people around the city volunteering in different ways.
Okay. And I know you mentioned, you know, therapists, and I know we have quite a few in the mental health space that join our discussion. So is there another number, or would you also recommend them to dial the 311?
No, well, you could look up the Baltimore Neighbors Network, and there's also something called pro bono counseling. Okay. And I had a chance to talk to the person who runs that. And that is an organization for counselors who can volunteer for exactly this sort of thing.
Okay, and then before I ask if there's any questions, I just have one more question for you. Can you say a little bit about the contact tracing?
Sure. So the idea behind contact tracing is we want to prevent the virus from jumping from one person to another. So if somebody's sick, then we can tell them that they need to isolate themselves and support them in isolating themselves. So then they won't give it to anyone else, but they may have already given it to someone. And so you look back and you go like, who did they have contacts with for close contact during that period of infectiousness? So let's say there are 5 people, 10 people. They say, oh, well, if you're talking about the last 4 days, here are the people I really spent time with. Then someone from public health calls those 10 people and says, hey, you've been with someone, you know, and they're close enough with them that you may be at risk for infection. You know, I'm not going to tell you who it was, as you know, the public health won't do that. Okay. But you know, you have been potentially exposed, and we're going to recommend, based on the nature of the exposure, you know, that you quarantine yourself for 2 weeks. That's what people have to do to stay out of harm's way. And the person goes, oh, quarantine myself for 2 weeks. I don't have any food. It's like, you've got to be able to provide food. You got to say, okay, we'll get you food. Here's how we're going to do it. You got to be able to support people in both isolation and quarantine. But if that person will quarantine themselves then they can't pass it on to anyone else because they're not having any. So you cut off the ability of the virus to jump to someone else. So you isolate the contacts, you isolate the cases, you trace their contacts, and you quarantine the contacts. And what you've accomplished is you made it very hard for the virus to find more people to jump into.
And how far back do you do the trace?
You know, some of those details are being worked out. It's probably 2 days before the onset of symptoms. So if I'm the patient and you're the public health worker and I go, well, I just found out I was positive today and today is Thursday, right? And they, well, when did your symptoms start? My symptoms started Monday. All right, let's start on Saturday.
Okay.
Tell me who you were with on Saturday. So I think that's probably more or less what they're going to do.
Now, Dr. Cooper, I know you have access to Dr. Sharfstein all the time. So I will allow Patti, if you have any questions, a question that you want to ask Dr. Sharfstein before.
Usually I'm the one asking Dr. Cooper questions. I just want you to know
that. Patti?
Ooh, I think you're muted. Oh, there you go.
Okay.
Okay.
Is it okay?
Yes.
Yeah.
Mhm.
Okay, good. Pleasure to meet you, and really excited about considering our entire world truly as our community on that level, because there has been probably very expeditious sharing of information.
I think the point she was making is that scientists have been sharing quite a lot of information, and that is absolutely true. I've interviewed some scientists who say every day they get on, and they're scientists around the world who are communicating about the coronavirus and what's now known.
Dr. Sharfstein, I will allow you then to give a final word before you run off.
Sure. Well, thank you again for having me. You're doing a really important service to get good information out to people. And I hope everyone who's listening is able to be a source of knowledge and information for those around them. And that's how we fight the virus, is with the spread of good information. So thank you very much for having me.
Thank you so much for joining us.
Take care.
Okay. Bye-bye. Mm-hmm. All right. Dr. Cooper, you're on. So we started out the discussion asking Dr. Sharfstein to tell a little bit about what he does and why he does it. So I will ask the same question of you.
Okay. Well, I'm a physician trained in internal medicine, and I'm also a social epidemiologist. So that means I study how diseases affect populations, but specifically how social factors, so things like the quality of housing or the social environment, the kinds of relationships people are in and the kinds of social connections they have and their exposure to discrimination and things like that, how that actually impacts their health. But as an internist, I've treated people with chronic conditions like heart disease and diabetes and kidney disease and asthma. And so I've been really interested in basically unpacking why there are racial and ethnic disparities in health, and especially in those chronic conditions, and what we can do to address them on multiple levels. You know, so all the way from the individual behaviors that people engage in, to the health systems in which they get their care, to kind of like the policies that we have that impact the social environment and the physical environment.
Now you do work in the equity, what is it, equity and health equity?
I do. I direct a center for health equity. So in that center, we do research, we do training, and then we actually actively engage with community organizations and community leaders to make sure that we are using the research to actually impact change and action to improve health.
I will ask that you help us maybe bridge the discussion.
Mm-hmm.
And I mentioned that, you know, I know you've done some work in sub-Saharan Africa.
I have. Yeah.
And we started out talking about the Global Health and Security Index, mm-hmm. and how the US was actually ranked number 1. Mm-hmm. And the majority of the African countries fall very low on that scale. And I know I know you have a connection to Liberia.
I do. I'm actually a native of Liberia.
Yes. And not, Liberia was ranked 111
Mhm.
out of 195.
Okay.
So not great.
Yeah, not at all.
But it was in the company of a lot of other sub-Saharan African countries. So can you talk a little bit about kind of the readiness of the sub-Saharan African countries for diseases like COVID-19?
Right. Well, a lot of those countries don't have sophisticated healthcare systems, right? A lot of them don't have a lot of the technology and the equipment and the numbers of staff with experience and clinicians with experience to deal with a pandemic like this, where thousands of people might be ill at the same time and might really need some sophisticated medical treatment to deal with it. So I think that's a big part of the problem. But they do have other things that can benefit them. And Dr. Sharfstein alluded to some of those things. And that is, many of them do have a pretty strong and robust public health system. So they do have a lot of those people that go out and do a lot of the contact tracing. So we know that during the Ebola epidemic, for example, one of the reasons Liberia was able to get that epidemic under control in a reasonable amount of time was because they did such an effective job of not once identifying a case, it's to do all of the contact tracing and to keep those people from spreading it further. So I would say that that's the sort of the silver lining of this cloud, is that if those countries are able to effectively use some of the public health strategies they've used before, that they should be able to effectively contain this epidemic. But again, a lot of it is going to depend on how able they are to do that. And some of it, frankly, is going to be some of the other things they did, which is really to work with community leaders to get the correct message out, and to have people who were trusted by the communities, so that those community members would listen and would engage in the right practices. So I think, building on those strengths, that's a real advantage. If they don't do that, then they're going to run into the situation where their healthcare delivery systems cannot accommodate the number of sick people. And that would really, really be a tragedy.
Now, how would you compare that to what we're seeing in some of the lower income neighborhoods in the Black and brown communities in the US in particular, because I know you've been doing a lot of work in Baltimore and having that experience of working in sub-Saharan Africa? Is there similarities? Are there differences?
I would say there are definitely similarities. A lot of the same issues that have caused people in Black and brown communities in the US to become sick are the same issues that plague poor people, but that's poor use of a terminology, that have really been a serious challenge to people in developing countries. So, it's things like not having high quality housing, or not having safe water to drink, or having enough healthy food to eat. It's not having enough money, to pay for basic resources. It's not having access to high quality education so that they can get jobs that pay a decent wage. So a lot of those things are very similar in sub-Saharan Africa and in Black and brown communities in the United States. The mistrust of authorities is something that we've seen in sub-Saharan Africa as well as in the US. There's a whole legacy of discrimination in this country, and even, to this current day. And so many people in Black and brown communities don't actually trust what's being told to them. They don't believe that this is a real virus, or they may not actually believe that it's necessary for them to do the things that they're being asked to do. So we see some of those same kinds of issues of mistrust and, all of the challenges I mentioned to you across the board. The difference is, in the US, we do actually have resources. We do actually have healthcare systems that are there to deliver the care, so that if we actually could get people to the right place, and if these resources were distributed more, equitably, that people wouldn't have those challenges. That's different, in sub-Saharan Africa, where really there are inequities there, but truly they don't have the capacity to handle all of the people that might need care. So I think those are the main differences and similarities that I see.
And, Patti, I'm hoping that your internet connection is back.
Yes, you should hear me now.
Yes, so Patti has been doing the work in Detroit. And we've talked over the last couple of weeks a lot about Baltimore. Can you just tell us a little bit about what's happening in Detroit in terms of the healthcare, the COVID-19, and how it's impacting communities there?
Absolutely. Well, as you suggest and know, Detroit has been very hard hit, and we've had strong leadership with our governor as well as the mayor of Detroit. It's helpful to know that in Michigan, the African American population is 13.6%, but also in Michigan, very sadly, 40% of the COVID deaths are African American. So that has raised many questions, to which the governor's response has been, and it will not only be this, but very importantly, she has designated her lieutenant governor, who is an African American man, to lead a group, a coalition actually, that is looking at racial disparity and COVID-19. Because we've done a lot of great data tracking in terms of total numbers, but we haven't necessarily been real clear at this point, and perhaps not many places, if any, in the country, in terms of how that breaks down in terms of races, socioeconomic. We know something about zip code. All of that's broken down, and our website for Michigan, michigan.gov, is wonderful in terms of resources and information. But obviously in a place like Detroit, many of the same things have been experienced. Early on, 4 weeks ago, we were really dealing with the dilemma of bus drivers being very threatened because they did not have protective equipment, and they were very afraid. And then one person actually did get infected, and it really created a lot of concern and a change in what was happening with bus driving. So we've tried to have very ready responses that had meaning, but to jump into the bigger issue in terms of the governor's task force, they actually have a very ambitious agenda to, within 90 days, have real-time solutions that will be operationalized as they go forward. And that really holds some promise for me, especially as we anticipate there could be a resurge of COVID-19 in the fall. I hope not, as we all do, but we have got to use the time in between to truly prepare and start to put fixes on these major gaps and prioritize well.
Dr. Cooper, are we seeing similar numbers in Maryland that Patti shared, that the disparity between the percentage of the population and the percentage that is being impacted or dying from COVID-19?
Well, I would say across Maryland, we're not seeing quite that level of disparity. It looked like there was somewhat of a disparity among African Americans and whites on the state level, with African Americans representing about 40% of the deaths relative to their representation in the population, which is around 30%. So not as much of a gap there. In the city of Baltimore, I think that the gap between Blacks and whites and between Hispanics and whites is a little bit greater and looking a little bit more like Michigan, but not quite to that extent.
And I know Maryland was a little slow in terms of releasing that data. So has that data broken it down in a way that we could really look at what is happening in Baltimore in particular?
It has. So the data has been broken down by race and ethnicity across the state, and then also by county and by zip code. So we are able to look at that. And we have seen that zip codes that have a higher proportion of minorities are having higher rates of infection and deaths. And that's in Baltimore City. But across the state as a whole, we're not seeing as much of a gap.
Now, when we put together this particular profound conversations, we said we wanted to look at the readiness in terms of the post-pandemic situation. But we do know that there is a prediction that there may be another wave coming in the fall. So we may not actually be looking at just the post, but the kind of the in-between, which means that we have a very short window of time to respond and to address some of the inequities that we've seen with this first wave. And I'll ask that question of either one of you. Is there something that you think that we should be doing at a policy level, what we should be doing at a community level, and what maybe the health system should be doing in order to address some of the inequities that we've seen in this first wave? So that was a compound question. You got anything you can pick from? You can pick from inequities at the healthcare level, policy level, community level.
Dr. Cooper, I'll just share briefly and then I'll let you expound because you've got a lot of wisdom with this, I know. I think that we really need to look at our vehicles of communication. And I think we've done a good job in many respects because radio and television are probably the most reachable for most people. But we are fooling ourselves if we think that smartphones or computers and websites are the way, because again, we have to think about access and how do people obtain and how can they digest and trust the information that they get. So I would hope that socially we really engage with leaders of various communities who are trusted and help empower them with information so that they can then provide hope as well as commitment from people in diverse populations so that there can be compliance. Because even when I look at the list of the 4 things that you can do to prevent an infection, wash your hands, keep distance from sick people. Well, how do you do that second one, especially if you in fact are in an apartment with multi-generations or you don't have food, many different compounding factors. So Dr. Cooper, I don't know what you would think about working with leadership in that way within various groups, and I think identification of key groups is important.
Patti, I do agree with what you're saying completely. I think that communication is key and also connection with community leaders. I think using the right vehicles and the right messengers. In that case, in some cases, it could be religious and faith leaders. In other cases, it might even be artists or other people who are well known and well respected, in these communities. Look at people of different age groups and different cultures and backgrounds, different religious orientations to be out there giving the messages. So I think that's going to be critical. I also think not waiting for people to come to us, but going to them. So a lot of the testing centers have been set up in places where people have to, travel to get to them. I think by using some of the data we have, we can identify which neighborhoods and which areas are more in need of testing centers, putting them there so people can come and drive through, but also like having testing resources that are available by mobile vans, for example, to drive over to people's neighborhoods where people don't have cars and it might be easier for them to just walk to get to. So I think working to do those kinds of things, working with policymakers around setting up resources for those kinds of efforts is important. I also think it's going to be really important to, on a state level, to expand Medicaid, to allow people to be able to apply for Medicaid, especially people who have lost their jobs during this time. I think making sure that there's adequate unemployment insurance provided to people during this time is going to be critical. I think, again, working with lawmakers around the legislation around the laws around not allowing people to be evicted at this time, but then also working with the landlords, because many of them are saying, they need access to some of these loans and financial resources so that they don't go under as well. So I think a lot of those efforts will be important at this point in time, as well as working with the small businesses and people who provide food in these neighborhoods. Really a lot of grassroots work and a lot of working with community-based organizations and businesses. So really looking for leadership on the local level and on the state level. And in Maryland, fortunately, we've seen a lot of that. So I'm optimistic about it, but it's going to take a lot of work, and we can't sort of just relax because we see a slight flattening of the curve.
So I'm going to ask you a little bit about the medical community because you are a physician. So what would you say to your fellow physicians and those other clinical people in terms of what we might be able to do better at a clinical level, at hospital systems, physicians, to prepare ourselves for this potential next wave that may be coming?
Yeah. Well, this is a really, really difficult time for people in the health professions, and so many of them are sacrificing a lot at this point in time. A lot of them are away from their families because they don't want to spread infection to their families, but at the same time, they're so committed to the work and to caring for patients that they're willing to do those things. They're willing to put themselves at risk, frankly, because knowing that a lot of hospitals and healthcare systems don't have adequate personal protective equipment at this time. So I think it's kind of the message to my colleagues is I have to be compassionate and empathetic towards them at this point in time. I think people are working under extreme conditions. They're making a lot of sacrifices. I think basically a message of the fact that we are all in this together. We're going to work to help each other. Many of us who don't do hospital-based work may actually step up to begin to do some of that so that our colleagues don't burn out. I think making sure that we work with the leaders, the administrators to procure the equipment that we need is going to be really important. I think that we want to make sure people guard against what happens when they are overly fatigued and stressed, and that sometimes they might end up taking shortcuts on their decisions, or treating certain people differently. But just we need to acknowledge with them and validate the real dilemmas in which they find themselves, because if there's a shortage of treatment or personal equipment, how are they going to decide which patient gets what and how aggressive they ought to be with some patients versus others? This is a very, very difficult situation, and I think we should just tell them that we're here for them, that we are in this together, and that we are going to advocate for everything that we need, so we don't put ourselves in the position where we are the ones that have to decide who lives and who dies, because nobody wants that kind of responsibility.
That is the subject for one of our next shows, is to really just talk about some of those ethical considerations. And I know Patti, you've been doing a lot of work in that space as well, just looking at those kind of issues when the healthcare professionals are put in a position of having to make these difficult decisions with little or no guidance.
Yes. Well, and I want to interject that I'm very proud of Henry Ford Health System in Detroit, because the communication has been at least twice a day, very clear and transparent. But to add to the complexity of healthcare is that yesterday it was announced that because of the very serious budget attack of the caring for this preponderance of COVID-19 patients in Michigan by our system at Henry Ford, as well as the Beaumont Health System, and the two of us have been the most heavily hit, we've had to each furlough 2,500 healthcare workers within our system,
Wow.
effective yesterday. And so the complexity there especially is the fear and the suspicion that arises in that kind of situation. And we have a very collaborative, pretty trusting environment, and yet that starts to get very personal. And at this point, I don't know, and it probably wouldn't be appropriate for me to share what kind of positions and people are affected. But even there, I immediately was concerned because we have such a heavy Black population in Detroit. 80% of Detroit is Black. And so a very heavy preponderance of our staff are very ethnic, have a lot of diversity in their ethnicity. Sorry, it's getting late for me. But I think it's important to realize that there are even different kinds of complexities and issues that are on the horizon. And then to anticipate that we might have to prepare for another swoop of this is almost mind-boggling. And yet we can't get into that mindset. We need to be always ready and become more ready as time goes on.
And what I've heard from this discussion is that, you know, there's opportunities, one, to support the physicians and other clinicians, looking at some of the stresses that they are under. There's also an opportunity for us to do the work to impact policy. And so I'm actually appealing to some of our listeners that if you have that skill set, where you can have an impact on policy, where you can provide, you know, clinical support to those that are out there on the front line as, you know, doctors and nurses, that you look for ways that you can do that. And of course, right now, a lot of this work is being done remotely, but there's so many systems that's set up now to be able to do some of that work remotely from, you know, telemedicine and these Zoom conferences that we're doing here. I just clicked over to look at some of our attendees, so I happen to be familiar with some of the individuals that are on the phone, and I know we do have at least 2 physicians that's on the line, and one of them will be our speaker next week, and that's Dr. Mark Pettis, who's out of Massachusetts, and we also have another physician, Dr. Anthony Thomas, who's on the call, who does work in Maryland, in Baltimore, Maryland. So I just want to thank all of you that are out there on the front line doing the work, because it's difficult work. And I just want to acknowledge that and personally give thanks to the work that you're doing. So, and I think we also have Dr. Hale, who's on the line as well. So thank all of you, and I'm kind of scanning through the list. So if I missed anyone, please accept my apologies for that. But we have about 8 minutes left for the call, and if anyone has any questions, if you can type those questions in to our chat or the question option. And while I'm just waiting for some of those questions to come, don't be shy about the questions. Even some of the doctors who I mentioned, throw some questions out there for us. But I just want to also just do a really, really special thanks to JHU, because JHU has really supported the profound conversation in Muslim Life Planning Institute. You know, Dr. Hale from JSU, we've had Dr. Sharfstein, Dr. Cooper. Last week we had, you know, Dr. G. So we're really thankful for the support that you have, the support that you've given. I know some of you are from Johns Hopkins here in Maryland, some are from Bayview, some are with Bloomberg, but it's all one family. So thank you. And Patti, who is with Henry Ford, we've been doing a lot of work. The Muslim Life Planning Institute has been doing a lot of work in Detroit, and Henry Ford hospital systems have been very supportive of the work that we've been doing in Detroit. So wanted to also acknowledge that. Okay.
You're welcome.
All right, and I did all of that talking, and I don't see any questions.
Shy people out there.
Huh?
We have some shy people out there, apparently.
Linda?
Yes.
Let me just share that something that we're doing at Henry Ford, and even within transplant, where I currently am working full-time, we are having twice a week meditation sessions, as well as psychological get-togethers that are really focused on a very narrow topic. It's only a half an hour, so it doesn't require a lot of people's time. And then we have many different ways of people connecting on staff through helplines, as well as through other support groups. And it's just been phenomenal to see all of that evolving very quickly, quite honestly. And it's so necessary because people are fatigued and devastated when they're having these close-up contacts with death and the threat of death day in, day out.
Right. I couldn't agree more. And I didn't mention, but Johns Hopkins has a lot of those similar things going on. The meditation, mindfulness sessions, actually morning, noon, and evening. All kinds of support services that are being offered. And even community members who are having sort of group sessions for a group counseling, or just people being able to share, grief groups. So it's been really an outpouring of, compassion, and a lot of people sort of putting themselves out there and offering themselves to be supportive to not only health professionals, but also to the family members and family members of people who have been ill, because, so many of them are going through so much at this time, not actually being able to visit with loved ones. But so there's a lot that's being done for people, letting people know that that health professionals are actually there with their loved ones, and reaching out to them by cell phone, by Zoom or whatever, so that they can speak to their loved ones during this time. I've just seen, this is an opportunity also where we can see the best of people sometimes in the darkest of situations.
Okay. Well, I want to thank both of you for joining us in this profound conversations today. And also, we have to give our thanks to our team, the team that makes this all happen. And those are my business partners and my brothers, Kareem Ali and Samuel Sharif, who were a part of the MLPI executive team. We also have Erica Christie, who is our engineer, and Erica does a lot of the work behind the scenes to make all of this happen. I know she sets up our calls with our presenters to do the tests beforehand. So thank Erica as well. And we look forward to, oops, it looks like we have one question. And the question is, thank you, Linda. So yeah, thank you very much for all of your, for all that you do to make this happen. And next week we will continue this discussion. And we have two presenters next week, which is Dr. Pettis and Dr. Galeas. So if you have not reached out to us to make sure your name is on our mailing list, please do so. And I will say that we will give you back 3 minutes. Or 2 minutes now. It's now 4:58. So thank everyone for joining us.
Thank you.
Thank you.
Okay.